Thank you for joining this seminar. My name is Andreas Xyrichis, and on behalf of the team, I am delighted to present our qualitative evidence synthesis on healthcare stakeholders' perceptions and experiences of factors affecting the implementation of critical care telemedicine. This has been a collaborative effort by all the review authors supported by the EPOC Norway team, and allow me to acknowledge Claire Glenton, Simon Lewin, Mark Johansson, Liz Paulson, and Chris Cooper, and I'm sure there's more people who have worked on this behind the scenes. Telemedicine has held a prominent role in policy and academic discussions for some time, but never before has it dominated the conversation, as it has during the COVID-19 pandemic. Telemedicine is being described as essential, transformational, the future of healthcare. So it had always been in part of the discussion, but never dominated in the way that it has recently. Now, whether these views will persist beyond the pandemic or whether this is a passing trend, that's a debate for another day. But for critics in particular, telemedicine has a role to play in containing current and future challenges. Across the world, we are seeing a sharp rise in critical care demand, which is outstripping capacity, both in terms of infrastructure and staffing. We are seeing variation in clinical outcomes from critical care at local, regional, and national levels, as well as unnecessary numbers for adverse events and near misses. In critical care, staff work under intense conditions, experiencing high levels of anxiety and burnout, and critical care resources are unevenly distributed geographically, with much of critical care expertise clustering in urban areas. So critical care telemedicine has been proposed as one possible solution to containing these challenges while having potential to improve quality, safety, and efficiency. For the purposes of this review, critical care telemedicine consisted of three features. First, continuous electronic recording of patients' vital signs at the bedside, linked to a computer system enabling display of real-time data. Second, provider-based decision support in the form of clinical decision-making algorithms and electronic alerts, and synchronous interactive provider-to-provider telemedicine using a remotely located team of critical care specialists, including doctors and nurses, who monitor patients. In an actual intensive care unit, the kit is barely noticeable among all the other equipment, but you may spot the mics, speakers, screens, and cameras installed on the ceilings or walls. That's just the front-facing aspect of the system. The magic happens behind, away from the unit, in the support center, which receives the live feeds of patient data and works to support bedside clinicians with expertise 24/7 through, for example, keeping an eye on at-risk patients and supporting staff at night when there's less senior people around. The evidence base in terms of the effectiveness of critical care telemedicine remains a bit sketchy. There are only a handful of high-quality RCTs with design weaknesses and some conflicting results in terms of the scale and level of effectiveness on various measures. Importantly though, these effectiveness studies lack detailed description of the context and process of the intervention. This is important because critical care telemedicine is not like introducing a new pill, tablet, or technique. It presents a fundamental change to the organization and delivery of the care system in critical care, and as such is influenced by many contextual factors. When we started working on this review, there was very little understanding of what we call theory of change, so the black box. What happens when you try to implement critical care telemedicine? And what are people's perceptions on the ground who end up using it? So we set out to identify, appraise, and synthesize qualitative research evidence on stakeholders' perceptions and experiences of factors affecting the implementation of critical care telemedicine. And this qualitative synthesis links to a Cochrane effectiveness review on interactive telemedicine, and we're examining telemedicine specifically in critical care. Given our implementation focus, we chose a relevant model to frame our work, so we followed the Consolidated Framework for Implementation Research, or CIFER, which is a comprehensive framework of factors that can influence the implementation process. And this is grouped under 5 domains of intervention and individual characteristics, the inner and outer setting, and the actual implementation process. So this offers a very detailed, transparent, and systematic approach to work with. We followed standard methodological guidance by the EPOC group on developing qualitative synthesis and worked closely with the team throughout. But rather than read this, let me show you quickly just some of the process we went through. So we started with a comprehensive systematic search in different biomedical databases using a combination of keywords, subject headings, and Boolean operators. We then exported our results to the Covidence platform, which allowed us to screen our results independently and keep track of our papers and our decisions, thus enhancing transparency of our approach. And this, of course, enabled us to produce an accurate and up-to-date flowchart. We also used Covidence to complete our quality assessment, again independently. We did have to use a custom quality appraisal form, for which we used the Critical Appraisal Skills Program questions from their qualitative research checklist. Doing this in Covidence allowed us to keep track of our annotations and comments, individual and final decisions, while at the same time keeping that close link with the actual papers and the text within those papers, which we used to inform our quality decisions. Some information could not be noted in Covidence, so we extracted it in Excel, so things like system vendors and types. But we also exported our quality assessment from Covidence to an Excel file, which allowed us easy access to our comments, judgments, and quotes from the papers without having to keep going back into Covidence. And what was really helpful with this Excel file is that it also allowed us to zoom out and at a glance see which papers had less or more methodological concerns, as well as which items from our quality appraisal checklists were more or less challenging. For example, this issue of researcher reflexivity was a concern for most papers, while other statements, sort of more straightforward, like having a clear statement, was less concerns. There were less concerns with. For our coding, we moved to NVivo. We imported all the PDFs of the articles and developed our coding tree based on the Cypher 5 domains and all the subdomains. And we used this to code all the papers. 2 people were involved in this process. And NVivo helped us to keep track of all the codes and text for each code and link directly back to each paper to the part of the paper that was coded. So we found that to really help with, again, the rigor, transparency of our approach. All of this work then helped us to work on our Great Circle assessment, or our circleizing, where we went back and forth to the quality assessment, coding, and our circle, starting very detailed to begin with, and then summarizing as we went along and refining. And all of this led to the nice summary of findings table we have in our published review, which Looking at it, one might think that we developed this over a day, but it took a lot of months of work to get here. In terms of results, we ended up with 13 studies published over a period of 10 years, all from the US and Canada, which is a limitation, and we took that into account in our circularizing. The majority of the studies included a range of stakeholders as we wanted, so bedside clinicians, telemedicine clinicians, directors, administrators. One study also included family members. We did hope for more studies with family members, but we were pleased to at least find one. The data from the qualitative studies came primarily from interviews and observations. 3 studies provided qualitative data analyzed qualitatively, but through open-ended survey questions. So that data was thinner, and that was also taken into account for our circularizing. In all, we had 20 review findings, most mapped under Cypher's domains of intervention characteristics, inner setting and individual characteristics, and the most prominent findings related to networks and communication, knowledge and beliefs about the intervention, and interactions between hub and bedside. Just some key findings for you here. In the main, ICU stakeholders, so everyone, acknowledge the potential of critical care telemedicine for improving patient safety and quality of care through things like standardization of practice to protocols, early recognition of patient deterioration or patients at risk, automated data collection, and value the potential of patients allowed to remain in their communities, in their local hospital, without having to transfer to a specialist center. Barriers to implementation stemmed from perceived disruptiveness within the everyday workflow and additional work imposed on bedside staff. The presence of a camera was also a concern for some staff, reported as a risk to patient confidentiality and to their autonomy. And these are just some of the codes showing how much they valued having that immediate access to critical care expertise. Hospital staff commonly noted the importance of adequate training, rehearsing of the process related to the use of critical care telemedicine prior to its implementation as rather important. They wanted and valued time for them to ask questions, discuss, practice, be trained, accept and normalize critical care telemedicine in the daily workflow. And while they did value prompt access to critical care expertise, at the same time, there were also concerns by some about the telemedicine team interfering with the decisions of the bedside team over patient treatment. So there were some examples of tension between the bedside clinicians and the telemedicine clinicians, sometimes leading to conflict. So issues around trust, teamness, respect, sense of professional community were important enablers to the implementation of critical care telemedicine. And again, some of the codes of people talking, but they feel that somebody is looking over their shoulder, and misunderstandings, miscommunication between the bedside and the telemedicine teams. To consolidate and synthesize our findings, to take it one step further, we looked at the relationships and links between them and proposed an implementation framework to guide future reviews and research on critical care telemedicine. We used the usual structure, process, balancing and outcome measures approach, commonly used within implementation science. Structure measures signifying the attributes of the wider service in which critical care telemedicine is going to be implemented. Process measures reflecting the way critical care telemedicine works. Balancing measures reflecting any unanticipated consequences or issues that can affect either positively or negatively on the process measures, and eventually outcomes. Outcomes that from the papers people were interested and concerned with, which was more than mortality, but issues around adverse events, issues around service utilization, and of course satisfaction, both patient and family satisfaction. In terms of our conclusion and our future directions in this work, we want to proceed with examining our proposed implementation framework and encourage more research to examine what we proposed and refine it and develop it further, especially with research outside North America. And to clarify, there is quantitative research outside North America, but there is less qualitative research and even less implementation type qualitative research in other regions of the world. And that is something that we do need to work on, because context does play an important role. We also want to involve more patient and family members in future research, because they are ultimately the recipients, the ones who get the most benefit. It is for them that the intensive care service works for, and their voice from critical care telemedicine research is minimal at the moment. It's also important to, in future research, to distinguish results between pre, peri, and post implementation of critical care telemedicine. Current research tends to conflate results and made it, well, impossible for us to tell which views, perceptions, experiences were as part of the pre or post or indeed peri implementation phase. And a reflection on using Cypher, which was exceptional in enabling a systematic and detailed approach to our coding, but it was rather linear as a framework, and that did made it more difficult when it came to pulling out relationships and trade-offs between its various components. And I understand that the team behind this model is working on refinements as I speak. Having a framework, however, implementation framework, was invaluable in this qualitative evidence synthesis, and indeed something that we highly recommend. Through this presentation, I wanted to share some of the key messages from our synthesis, but feel free to read our full review on the Cochrane library, and we're happy to be approached if you're interested in this area of research. That is all from me. Thank you for listening.